Hello and welcome to our first 100 question radiology anatomy revision session. Now, over the last couple of months, I've created 20 different anatomy videos on the channel, and what I've done today is taken one piece of anatomy from each one of those videos and asked 5 different questions about that anatomy. And I've tried to ask the questions in a similar way that gets asked in our Radiology Anatomy Part 1 exams. Now, if you find yourself not being able to answer one of these questions, I'd encourage you to go back to that original video and refresh some of your knowledge on that anatomy. Hopefully, this session will allow you to realize where you're really strong and which parts you need to revise a little bit more. So without further ado, I'm going to get into the first question, and I encourage you to pause the video, answer the questions yourself, and then follow along with me as I go and answer those questions. So let's have a look at our first image here. Again, pause the video if you need time to answer these questions, and then join with me as I go through the answers. So what type of scan is this? Well, we have an axial slice CT scan of the brain. We know it's a CT scan. Our bone is bright here. Our bone is dense. We've got brighter gray matter than we do white matter, which is classic of a CT scan. More dense gray matter than white matter. And we can see that we're at the level of the lateral ventricles here that are separated by this septum pellucidum. We're asked to label this structure that's identified by this red outline here, and this is what's known as the lentiform nucleus, which is one of our basal nuclei. Now, it's called the lentiform nucleus because it has this lens shape, and it's made up of 2 separate nuclei. It's made up laterally of our putamen or putamen and medially by our globus pallidus. Now, we group these because of their location and their shape, but they actually don't act as a functional unit. Our putamen and our caudate, which we can see the head here, together act as a functional unit and are known as the corpus striatum. So we asked if this is gray or white matter. Well, we can see that our gray matter is lighter or brighter on this image than our white matter. It's more dense than the white matter. And we know that our basal nuclei are made of gray matter, and we can see in this image that they are lighter than the surrounding white matter. So this is gray matter. Now, you might be hearing me say basal nuclei, not basal ganglia. And I'd encourage you to make that switch, say basal nuclei, because we are talking about gray matter collections within the central nervous system. Those are nuclei. When we talk about collections of cell bodies outside of the central nervous system, then we talk about ganglia. So the correct term is a basal nuclei. Now, we asked to name the tract that lies medial to the structure, this white matter tract here. This is what's known as our internal capsule. Our internal capsule has an anterior limb, a genu or a knee, a bend in the internal capsule, and a posterior limb. This anterior limb is separating our lentiform nucleus from our caudate head, and this posterior limb is separating our thalamus from our lentiform nucleus. And this internal capsule has efferent and afferent fibers. Efferent fibers going from the cortex down to the spinal cord, and afferent fibers coming up from the thalamus towards our basal nuclei. Let's move on to our next question. Give yourself some time to answer this. We are dealing here with a coronal slice CT scan, and we've bone windowed this CT scan. We've lost the detail within the soft tissue, and we can see good detail within the bone. So this is a bone windowed CT scan. We're asked to name this space here. Now, this is a slice that will come up commonly in anatomy exams because what we have here is what looks like an eagle. We've got the beak heading to the head, down to the wings of the eagle, and then the beak coming to this proud chest of the eagle, and this eagle is sitting on a little branch here. And this gap here is what's known as our hypoglossal canal. Now, you'll be familiar with this image if you've watched our skull base foramina video, and the structure that passes through this hypoglossal canal is the hypoglossal nerve, our 12th cranial nerve. Now, we asked to identify which bone the hypoglossal canal goes through, and I've asked you this question because this is something that people get wrong often. When we cut this in the coronal slice, this kind of looks like a vertebra, but in fact, this is our first vertebra. This is C1. Here's our dens or our odontoid process of C2. And this is in fact our occipital bone, the occipital condyles of the occipital bone. Sometimes we call this C0. We have C1, which is our atlas, C2, which is our axis, and some people call the occipital condyles C0 because it kind of looks like a cervical vertebra. Now, these occipital condyles are lateral to our foramen magnum. They create the opening to the skull vault itself. We asked, where does this nerve originate? Where does the hypoglossal nerve originate? And you'll see when we follow our cranial nerves from 1 to 12, the nuclei of the cranial nerves come from the midbrain and they head down sequentially as we've numbered them from 1 to 12. Now we're dealing with the hypoglossal nerve, which is the 12th cranial nerve, the last cranial nerve. So it goes without saying that it's in the last part of our brainstem, which is our medulla. And the hypoglossal nuclei arises from the superior and posterior portion of that medulla before heading forward as the hypoglossal nerve. Let's move on. We've done 10 questions. Now we're going to move on to question 11. This slice comes from our paranasal sinus video, and we asked to identify what type of scan it is. Again, we've got a coronal slice scan, no soft tissue detail. We've got our bone windowed. So this is a coronal CT bone windowed of the face and head. Now we're asked to label this opening, and this is what's known as the maxillary ostium, which forms part of our osteomeatal complex. Our maxillary ostium, our infundibulum, this unsnit process making up the inferior border, into our hiatus semilunaris, draining the maxillary sinus. Which sinus does this drain? The maxillary sinus, into the middle meatus. Which space does it drain into? The middle meatus. Now these gaps here are called meati, and these soft tissue structures are called turbinates here. So we're draining our maxillary sinus through our osteomeatal complex into our middle meatus via the hiatus semilunaris. Now we ask which other sinuses drain into this space. Well, it's our maxillary sinus, our frontal sinus via the frontal recess, and the anterior ethmoidal air cells. Now the way you can remember this is our frontal sinus is a very anterior sinus. Our maxillary sinuses also lie quite anteriorly. So it's the anterior ethmoidal air cells that drain into this middle meatus. Our sphenoid sinus and our posterior ethmoidal sinuses can be grouped together as posterior sinuses. And if you find yourself not knowing these terms, go check out that paranasal sinus video. It's an area that people get confused very easily, but it's actually really simple anatomy once you understand the various different structures. Now, before we move on to our next question, I just want to make a 10-second announcement. I've spent the last couple of months pouring all my time and energy into creating a radiology physics course, which will be available in the link down below. I've tried to make it as concise, accurate, and easy to follow along as possible. I've created these customized diagrams showing you the electron orbitals, the X-ray tube, computed radiography, Bremsstrahlung radiation and filtration, and these are just some of the topics that we are going to cover in that course. Let's move on to our next question. Pause the video if you need more time. We asked what scan this is. Well, this is actually a 3D volume rendered CT angiogram. So we've got our vessels that had contrast within our CT angiogram, and we've been able to use that data to create or reconstruct this 3D image of the vasculature of the head and neck. We're asked to name this structure here. Well, we have our aortic arch coming here, and our first major branch of the aortic arch is what's known as our brachiocephalic trunk. Now, it's not the right brachiocephalic trunk. By definition, this is a right-sided structure. Now, which two branches does this divide into? It divides into our right subclavian and our right common carotid artery. Now, a common mistake that people make when answering anatomy questions is they don't lateralize. They say subclavian artery and common carotid artery. It's the right subclavian artery and the right common carotid artery. Another thing, there's no such thing as a carotid artery. It's either a common carotid artery or an internal or external carotid artery. Now, what is this called when the left common carotid artery shares a common origin with the brachiocephalic artery? So here's our left common carotid artery and our left subclavian artery. Those are both coming off the aortic arch. Sometimes this left common carotid artery comes off of this brachiocephalic trunk, and that's what's known as a bovine arch, because that variant is often seen in cattle. Now, name the two branches of the aortic root. And I've asked you this question because sometimes we forget that there are two small branches that come off the aortic root before we reach our aortic arch. And that is our left and right coronary arteries. So our left and right coronary arteries come off the aortic root. Some people call those the first branches of the aorta. Some people separate the aortic root from the aorta itself. Let's move on to question 21. We asked to identify what type of scan this is. Now we can see here we're not dealing with a CT. We've got dark bone, we've got bright subcutaneous fat here. We can see that our gray matter is darker than our white matter. And we can see that our CSF is dark in this image. So we know this is an axial T1 weighted MRI brain. We asked to name this small CSF filled space here, and this is what's known as our cerebral aqueduct. It connects the third ventricle and the fourth ventricle. Our interventricular foramen of Monroe connects our lateral ventricles to our third ventricle, then our cerebral aqueduct connecting our third ventricle to our fourth ventricle. We're asked to name the 3 cisterns that we can see in this image. Well, where are we here? We're at the level of the midbrain. We can see our cerebral peduncles here anteriorly, our mammillary bodies, and we can see our culiculi posterior like this. And just knowing that where we are, we can then identify these CSF-filled spaces around the midbrain. Between our cerebral peduncles is our interpeduncular cistern, which houses our mammillary bodies and lies between those peduncles. Posteriorly, we have our quadrigeminal cistern sitting behind the quadrigeminal plate, the superior and inferior culiculi of the midbrain. And then connecting our quadrigeminal cistern to our interpeduncular cistern around the midbrain is our ambient cistern. Ambient temperature, the surrounding temperature, this is our ambient cistern. Interpeduncular cistern, ambient cistern, quadrigeminal cistern. Then question 25, the midbrain posterior to this is known as the midbrain posterior to the cerebral aqueduct, this section here is known as the tectum of the midbrain. This larger anterior section here is our tegmentum. We can separate the midbrain into an anterior and posterior section at the level of the cerebral aqueduct here. Moving on quickly, we're a quarter of the way through. I hope this is helping. If it is helping, please like the video to let me know that this is helping. And my plan here is to do 100 questions in neuroanatomy, 100 questions in thoracic, abdominal, lower limb and hip, shoulder and arm. And if that sounds like something that you would want, please let me know in the comments and I'll go about making those 100 question anatomy series. So let's move on to question 26. Have a look at this image here. We're asked to identify what type of scan it is. Now you'll see I'm asking you on every one to identify what type of scan. And it's really easy marks when it comes to your anatomy exam. You're often asked what type of scan it is. And there aren't actually that many types of scans, especially if you're comparing it to the amount of anatomy that you have to learn. So this is free marks. You've got to learn the various different types of scans and what they look like. Here we're dealing with a 3D volume rendered MR angiogram here. Another point about an MRA is that we can rotate this image in all different directions, and I've just given you a screenshot here. So it's often quite difficult to know what's left and what's right. And so when you're lateralizing your anatomy, just be careful about whether you are actually confident about saying this is a left-sided structure or a right-sided structure. Here we asked to label this artery, and this is what's known as our basilar artery. We can see our vertebral arteries coming up, our basilar artery, which will eventually divide into our posterior cerebral arteries, forming the posterior circulation in our circle of Willis. What's the origin of the basilar artery? Well, it's the confluence of those vertebral arteries. Those vertebral arteries have come from our subclavian arteries, come through the transverse foramina of our cervical spine, headed up towards the pons, anterior pons, and then combine to form our basilar artery that runs between the pons and the clivus anteriorly. Now, which cistern does this run in? Well, we know it's anterior to the pons. This is our prepontine cistern that the basilar artery runs within. And finally, question 13, name the only other non-paired artery within the circle of Willis. Well, we have our circle of Willis here. We've got our ICAs, our internal carotid arteries, dividing into our middle cerebral and our anterior cerebral, both of which are paired arteries. Our posterior cerebral and our posterior communicating arteries are also both paired arteries, and it's this artery here that's the only other non-paired artery within the circle of Willis, and this is our anterior communicating artery. Question 31, we've moved out of the head and neck. We're now within the shoulder joint here. We asked to name this type of scan. Now this can be quite difficult for a lot of people. We know we're dealing with an MRI scan. Our bone is dark here. It's not bright like a CT scan. And we know we're dealing with the coronal plane. And this type of MRI is actually what's known as a PD-weighted MRI image, a proton density weighted MRI image. Now what we do in a proton density image is we try and negate the T1 and T2 differences between the various different tissues within the image that we are looking at. We do this by increasing our TR. We make a long TR to negate the T1 differences and make a short TE, a short echo time in our MRI sequence to negate the T2 differences. And what we get is bright fat as well as bright fluid. The fat and fluid have very similar signals, and we get really dark tendons, dark cartilaginous structures, giving us good contrast, especially when we're looking at MSK images. We can see that there's fat within the marrow here, and that's why we have bright signal within the bone as well. So we asked to name this black structure here. Well, this is our supraspinatus muscle and our supraspinatus tendon going over here. Now, where does this tendon insert? Well, it inserts on the superior aspect of our greater tubercle of our humerus. We know that there are two other rotator cuff muscles that insert there just below this insertion. That's our infraspinatus and our teres minor coming up posteriorly, attaching to that greater tubercle. Our subscapularis comes across more anteriorly to the humerus, attaching to that lesser tubercle there. So we've answered number 33, where does it insert? 34, it courses inferior to which bone? So we can see that this tendon is coursing inferior to this bone up here, and this is our acromion here. Now there are lots of different variants of acromion shape, and some variants can actually impinge on this tendon. So this is really clinically important to see that this tendon has good space running underneath this acromion here. And what artifact can we see on this image? I'll highlight the artifact here. This is what's known as a magic angle artifact. I'm not going to go into the physics exactly of the magic angle artifact, but what we can see is we've got hyperintense signal here compared to the tendon that we are looking at. Now, there's not tendinopathy here. This is in fact an artifact of an MRI. And this artifact very basically stems from the fact that the molecules within the collagen of our tendon here at a certain angle, at about 54.7 degrees to our MRI B0 signal, we get what's known as a magic artifact. And this is to do with the quantum mechanics and the interaction of spins within an MRI. And some of our vectors actually have direction. Now, I don't want to get too much into the physics, but the take-home point here is we mustn't call this pathology. This is in fact an artifact in the MRI. And if we were to do, say, a T2 weighted image, we wouldn't see that artifact. Or if we were to change the orientation of the shoulder joint within the MRI machine, that artifact would disappear as well. Question 36 asked what type of scan this is. Now, we've just looked at this type of scan. We've got bright fat, we've got bright marrow signal within our bones. We've also, if we can see a little bit of fluid here, that's also bright. Again, we are dealing with a proton density MRI. This is an axial proton density MRI of the knee. Name this bone. Hopefully, most of you will know what this bone is. This is the patella bone. And we asked if this arrowhead here is medial or lateral on the patella bone. Now, a good way to know this is our longest facet is lateral. Again, our sartorius, our gracilis, and our semitendinosus also lie medially. Another clue that this is medial. Often there's a larger fat pad medially as well. So this is our medial side, and this there is our lateral side. Now, this bone lies within which tendon? Well, superiorly, we have our quadriceps tendon coming to our patella, and then our patella tendon heading down and inserting on our tibial tuberosity. What structures prevent this patella tendon from dislocating laterally like that? Well, the first is this medial retinaculum here, a fibrous tissue that is preventing that patella from moving laterally. And secondly, we have this groove within the femur. This is our trochlear groove. Trochlear meaning pulley. You'll see trochlear coming up over and over again in anatomy. Our trochlear bone of our elbow, our trochlear muscle in our eye muscles. Anything that glides within a groove like a pulley, we call a trochlear in anatomy. So when in doubt, if you're unsure and you see a groove shape, just call it the trochlear. You never know. You might get it right in the exam. So let's move on. We've moved away from the musculoskeletal. We're now in the abdomen, asked to name this type of scan. We're dealing with an axial slice. That's a good place to start. And we know we're dealing with a CT. We can see our ribs here are bright. We're within the abdomen. And we can see the aorta here with contrast within the abdomen. So what we've got here is an arterial phase contrasted axial CT scan of the abdomen. We can see the vessels within the liver here. The veins in the liver don't have any contrast. So we know that this is an arterial phase image. We're asked to name this structure here. We can see that this is a vessel with contrast within it, likely coming off the abdominal aorta. You can see that the vessel closest to it came off later than the vessel further away. As we're heading down, our vessels come off. The one that came off earlier will be further away from the abdominal aorta. This is a common mistake that people make. Some people call this the superior mesenteric artery, thinking that it's lower down than this. This is in fact the superior mesenteric artery. This is our celiac artery or our celiac trunk, the first branch of the abdominal aorta. Name the three vessels that branch off the celiac trunk. Well, we have our splenic artery. We can see some of that splenic artery here. A tortuous artery heading towards the spleen. That gives off some vessels down to the pancreas below it and then also supplies arterial blood to the spleen. We then have our left gastric artery. We can perhaps see some of that left gastric artery coming there into the lesser curvature on the left-hand side of the stomach. And then we have our common hepatic artery, which becomes our proper hepatic artery, and our right and left hepatic arteries. So splenic artery, left gastric, and common hepatic artery are the three main branches off of our celiac trunk. Now that anatomy does vary quite a lot, but we need to see those terminal branches. They will always head somewhere from that celiac trunk. Now, which part of the GIT does this vessel supply? It supplies our foregut. Celiac trunk is our foregut, SMA, midgut, IMA, hindgut. So our foregut from that very distal part of our esophagus, supplying our stomach, the first part of the duodenum, right up to the second part to our ampulla vata in our second part of our duodenum. It also, as we've seen, supplies the liver, supplies the spleen, and supplies blood to the pancreas. Now, what level does the celiac trunk originate? Well, it comes out of the abdominal aorta as it pierces the diaphragm. We know that the abdominal aorta pierces the diaphragm at the level of T12, so the celiac trunk usually comes out at T12. Again, staying within the abdomen, you can see there's some subtle changes here. Again, we're dealing with a CT scan, bright bones on this scan. It's an axial slice, but our contrast has changed. Let me go back one image, look at the aorta, see how bright the aorta is. It gets a little less bright as I head back to this image. Look at our vessels here, our veins within our liver. You can see they're a little bit brighter in this image than they were in this image. They were quite dark. So we've changed our phase. We've still got contrast within this image, but the phase of the image has changed. Look how the liver gets slightly brighter here as we head to this next image. This is what's known as our portal venous phase. We've waited to take the image, and now that contrast has allowed time to get into our venous system, into our portal system, and sequestrate within the various different organs within the abdomen. So this is a portal venous phase, axial CT abdomen. Now we divide the liver into multiple segments, and the classification system we use is called the Quinault classification system. We divide it into 8 different segments. Now the segment we're looking at here is a posterior segment. It's on the right hand side in the right lobe of the liver, and we need to figure out, is this a superior posterior segment or an inferior posterior segment? Easiest way to do that is see, can we see kidneys? We can't see kidneys here, and we can actually see adrenal gland here. So we know we're lying superiorly. This is a superior lobe of the liver, and this is actually segment 7 of the liver here. When we're looking at our patient, we label the segments in a clockwise fashion, starting at that left upper border here as segment 2. We then go inferior 3, 4A and 4B, and then move around 5, 6, 7, and 8. 7 and 8 are superior segments. Here is 7, and here is 8. Now, I'm not going to go through all the classification system here. We've got a whole video on that, and people have found it really helpful to try and visualize the various different liver segments. We also see how many segments are visible here. Well, I've said we've got our 7th segment here. We've got segment 8 here, segment 4A here, segment 2 here, and we have our caudate lobe here, another segment. So we can see 5 different segments within this image. Now, which vessel drains the hepatic veins, these veins that we've used to divide the liver into its various different segments? Those then drain into our inferior vena cava, taking that blood then to the right side of our heart. We're halfway through. I hope you are finding this useful. This video might be one that you need to come back to. It's quite tiring to sit down in one session, go through all of this anatomy, especially if some of it is new to you. But if you are enjoying it, let's move on to our next image. Here we are now in the thorax. We can see lungs, we can see breast tissue, we can see the mediastinum centrally here. This is a axial CT scan of the thorax, and we are in the lung window. The detail here is within the lung. Asked to name this structure, we can see we've just bifurcated our trachea at the carina of the trachea into our right main bronchus and our left main bronchus. And this is our esophagus posteriorly here. Don't get confused, that's not a bronchus or a branch of our bronchial tree, that is the esophagus there. So we've just bifurcated, we've got our right main bronchus. The first branch that comes off our right main bronchus is our right upper lobe bronchus. Our right upper lobe bronchus then separates into an anterior bronchus and a posterior bronchus, and it's got one more branch, an apical branch. If we were to scroll into the screen here superiorly, we would see that apical branch. Anterior, posterior, and apical segments coming off that right upper lobe bronchus. After that right upper lobe bronchus comes off of our right main bronchus, that right main bronchus is then called our bronchus intermedius. That bronchus intermedius is then going to give off our right middle lobe and our right lower lobe. right middle lobe anteriorly like that, right lower lobe more posteriorly and inferiorly like that. Now, sometimes this right upper lobe bronchus can actually come off the trachea, and that's what's known as a tracheal bronchus, or some people call it a pig bronchus, a variation that is often seen in pigs. This right upper lobe bronchus coming directly off the trachea. Moving on to question 56, we're now back up in the head and neck. We see our teeth here anteriorly, our muscles of mastication here. We asked to identify the type of scan that this is. We can see we've got bright fat here. Our bones are dark. This is not a CT scan. This is an MRI scan. If we look at our spinal cord here, it's surrounded by dark fluid. That could be a T2 weighted with fluid suppression or a T1 weighted with naturally dark fluid. And what we can do is look at our spinal cord here. Our spinal cord is opposite to the brain. Our brain has gray matter on the outside, white matter on the inside. Our spinal cord has white matter on the outside, gray matter on the inside. You can see our white matter is more hyperintense as opposed to our gray matter here. We're dealing with a T1 weighted image. This is an axial T1 weighted MRI of the head and neck. Let's label this space here. This brings us to our deep neck spaces. This is what's known as our parapharyngeal space, a really important space when looking at head and neck anatomy. You can see it's bright here. It's predominantly filled with fat. It's surrounded by all our different other neck spaces. We've got our parotid space here, our carotid space here, our pharyngomucosal space here, our masticator space here. And any mass in any of these spaces is going to displace this parapharyngeal fat, allowing us a red flag to say, wait, there's something pushing this fat. I need to go and look for a mass in those various different spaces. Now, which fascia contributes to this lateral border of this space? Well, we know that our superficial layer of our deep cervical fascia covers our sternocleidomastoid muscle, our trap muscles, and then as we head up superiorly here, covers our parotid space and our masticator space. So this is our superficial layer of our deep cervical fascia. Are we dealing with a suprahyoid or infrahyoid neck? We separate the neck spaces by the hyoid bone. Here we are superior to that hyoid bone. As soon as we can see our parapharyngeal space, we know we are much above that hyoid space. We are in our suprahyoid neck space. X-ray anatomy now, what type of scan is this? Now I've just said X-ray anatomy. That's a misnomer. Try and get away from calling this an X-ray and move to calling it a radiograph. The image itself is a radiograph. The X-rays are the electromagnetic waves at a certain frequency and energy going through the bones. So we call those X-rays. The electromagnetic waves are X-rays. This is a radiograph. What we have here is a lateral radiograph of the right elbow. We're asked to name this structure here. We know that this bone here is our radius. Our ulna is the bigger bone at the elbow joint, having our olecranon coming around like this. Here is our radial head. So the correct answer here would be our right radial head. Our right radial head then articulates with the little head, the capitellum of our humerus. So this radial head has a shallow fossa here, articulates with the capitellum here, and it allows us to pronate and supinate, moving our radius without moving our ulna. If you pronate and supinate here and hold your olecranon, you see your ulna doesn't move at all. That radius moves, and that movement there is what's known as a pivot joint. So this creates a pivot joint here, a radiocapitellar joint. Now, is this radial head medial or lateral? I've included this because some people forget anatomic position is palms facing forward, out like this. Our radius is on our thumb side, the only finger that can do a radial movement. So our radius is lateral. This radial head is lateral to the patient. Another radiograph here, we are looking at a frontal radiograph of a skeletally immature elbow. And this is on the left side, so a left frontal radiograph of the elbow. What structure is this? We can see that this is an ossification center. Our radial head and capitellum ossification centers. Medial to that, we know that this is lateral. The radial head side is lateral. This is medial. This is our medial epicondyle ossification center. Now, which ossification center appears first? We know our mnemonic, crito, C-R-I-T-O-E. Capitellum appears first, radial head, internal epicondyle, trochlear, olecranon, and external epicondyle. So this capitellum is the first ossification center that will appear first. Which ossification center appears after the label structure? This is our medial epicondyle or our internal epicondyle. Our next structure is going to be our trochlear ossification center, appearing here. Our trochlea and our olecranon generally appear around the same age, about 10 years of age. Now, what age does this appear? This is a bad question. When I say this, I'm meaning the internal or medial epicondyle. Well, this appears at about 7 years of age. Capitellum at 1, radial head at 5, internal epicondyle 7, 10 for our trochlea and olecranon, and 11 years for our external or lateral epicondyle. Question 71, we're getting to the end. This is a real marathon. I hope you are finding this useful. Again, now we are in the abdomen. It's an axial CT scan of the abdomen. There's some contrast within our veins in the liver. This is a portal venous phase, a contrasted portal venous phase, axial CT scan of the abdomen. Which part of the duodenum is this? Well, this is D1. We can see our stomach here, our pylorus going into our duodenum. That duodenum will then head posteriorly, run inferiorly as D2, cross the midline as D3, head superiorly as D4 before becoming jejunum. Is this intra or retroperitoneal? This first part of our duodenum is intraperitoneal. Those D2, D3, and D4 are retroperitoneal structures, but this first part initially is intraperitoneal. It has its own mesentery. Which section is the major duodenal papilla located? Well, that is in D2. That's where our pancreatic duct, our common bile duct, insert into that duodenum, releasing their contents into the second part of the duodenum, D2. At what point does the jejunum start? Well, we've said D4 heads up and then becomes the jejunum. That's the DJ flexure at the ligament of Treitz. So at our ligament of Treitz, the DJ flexure, that small bowel then becomes jejunum. So these questions were from our intraperitoneal cavity talk. Let's move on to our retroperitoneal cavity talk. The same CT scan here, an axial portal venous phase CT of the abdomen. Name this organ here. Well, we can see anteriorly is our duodenum that we just looked at. Posterior to that is our pancreas here. And this is the body of the pancreas before heading out towards the tail of the pancreas that heads towards our spleen. Now, which retroperitoneal space does this occupy? If you don't know the retroperitoneal spaces, I'd highly recommend that you go and look at that retroperitoneal anatomy video and really understand the different spaces within the retroperitoneum. This is what's known as our anterior pararenal space. It has our pancreas, it's got our ascending and descending colons, as well as our duodenum within this space, bordered anteriorly by our parietal peritoneum. And then we asked, what is the posterior border? Well, the posterior border of this is our anterior renal fascia, or our Gerota's fascia. You'll hear Gerota's fascia often. So this pararenal space lies between our parietal fascia and our anterior renal or Gerota's fascia. Now name this organ's blood supply. Earlier I told you that the splenic artery gave some arteries down towards the pancreas, so our pancreatic branches of our splenic artery, as well as our inferior and superior pancreatoduodenal arteries. Again, we cover that blood supply in our abdominal aorta talk. We've got 20 questions to go. Maybe grab yourself a cup of tea or coffee. Last push, get through these final 20 questions. All the work that you're putting in here is really going to translate into exam success. I am sure of it. Let's go on to question 81. Here we have an AP radiograph of the right wrist. And we also identify this space. We often get stuck on these carpal bones trying to figure out, can I name all the various wrist bones? And we forget about the cartilaginous structures that surround the wrist. So I'm going to focus on some of those structures here now. This is what's known as our triangular fibrocartilage complex here, filling this space above the ulna, allowing pressure, when we put pressure on that wrist, to then be translated through the wider radial bone here and not putting pressure on this thinner ulnar bone. Which fibrous band covers the ventral aspect of the wrist? Now remember, anatomic position, our hands, our palms are facing forward. This is ventral. This is the ventral side of our wrist. This is the dorsal side of our wrist. And we have a piece of fibrous tissue going across here known as our flexor retinaculum. It allows those flexors to stay within the wrist. If we bend our wrist, those flexors don't tent across here. That flexor retinaculum keeps them close to our wrist. Our flexor retinaculum attaches to 4 different lateral points in the wrist: our hook of our hamate, our pisiform, our trapezium, and our scaphoid here. They act as anchor points for that flexor retinaculum to go across the wrist, making a nice deep space for our median nerve as well as our flexor tendons to run through the wrist here without rubbing on bones. It gives it some height to that wrist. What type of bone is the pisiform bone? Well, that's known as a sesamoid bone. It lies within the tendon of our flexor carpi ulnaris. Question 86, we've gone back up to the top of the head here. We've got a lateral radiograph of the cervical spine, a common image that you're going to be looking at within your practice. Now, what's the structure here? Well, this is a vertebral body. Let's try and count which vertebral body it is. You can see our anterior process or our anterior arch of our C1, C2 here, 3, 4, 5, 6, and C7. So this is the vertebral body of C7. The soft tissue anterior to this soft tissue here is known as our retrotracheal soft tissue, or retrotracheal space here. Retropharyngeal space here is above the level of C4, a much thinner space there. We allow the maximum thickness here. It varies between texts, but generally we say 20 millimeters or 2 centimeters of retrotracheal space here ahead of our C7. Now, which nerve root exits inferior to this bone? Which nerve root comes out here? I want to mention this because we've got 8 cervical nerve roots, but only 7 cervical vertebrae. That first C1 nerve root comes out above C1. So our cervical nerve roots come out above their respective vertebrae. So the nerve root coming above C7 would be C7. The nerve root coming below would be called C8. Then our thoracic vertebra will have T1 coming below T1. So the corresponding vertebra is now above the nerve root that's coming out in our thoracic and lumbar spines. Last 10 questions. We have now got a frontal AP radiograph of the pelvis. This is the left-hand side of the patient. We asked to name this structure. This is our anterior superior iliac spine. And to be more specific, this is our left anterior superior iliac spine of the pelvic bone or of the ilium. Which muscle attaches here? Well, we have our sartorius muscle heading from this ACES all the way down to the tibia. It bypasses that femur. This is a long muscle that runs from lateral medially. It crosses the hip joint as well as the knee joint. That's the only muscle that attaches here that heads down towards the leg, but we also have a ligament that comes from here and heads towards our pubic bone, and that's what's known as our inguinal ligament. It makes up the floor of our inguinal canal. It's a really important ligament, especially if we're doing general surgery and we're doing hernia repairs. We need to know this anatomy quite well. Name the 3 bones that fuse to form the pelvic bone. Well, in normal development, the pelvic bone starts as 3 separate ossification centers, 3 separate bones that then fuse at the acetabulum to form this pelvic bone. We have our pubis here, our ischium, and our ilium all fusing to form the pelvic bone. Now you've made it our final 5 questions. We're back up in the neck. We've got an axial CT. Our bones are bright here. Our soft tissue here. We've got an axial CT of the neck. We're at the level of the cervical spine. We can see these transverse foramina creating complete rings, allowing for those vertebral arteries to travel up lateral to the cervical spine. And we have our hyoid bone anteriorly here, wrapping around our airway. Name this space. This is our right vallecula here. Our right vallecula is separated from this left vallecula by this median glossoepiglottic fold here, a piece of tissue that attaches the base of the tongue to our epiglottis, which is our next question. What is this soft tissue structure posterior to the vallecula? Our epiglottis. Now, which laryngeal space is this image? Which slice are we in our larynx? Well, we separate our larynx into supraglottic, glottic, and infraglottic spaces, and that helps us when we're staging laryngeal cancers. Here we are in the supraglottic space. Our epiglottis is superior to our true vocal cords. And lastly, which structure defines the inferior border of the larynx? I said we divide the larynx into various segments. The superior border is that tip of the epiglottis. Starting at the tip of the epiglottis, below that is all larynx, all the way down to the inferior border of our cricoid cartilage. And the larynx has some incredible anatomy with our false vocal cords, our true vocal cords, our arytenoid cartilages, our thyroid and cricoid cartilages, our aryepiglottic folds. It's a really intricate structure, but once you understand that anatomy, it's a really important part to look at your CT scan, and you'll start picking up things that maybe your colleagues aren't picking up because you have good understanding of that anatomy. So I hope that 100 questions wasn't too much. Many of you had asked for 100 questions in the comments, so I take no responsibility. If you've made it this far, thank you so much for supporting me by watching these videos. Again, I've released a physics course. If you're studying for radiology physics, I think this course will be really helpful to you. Go and check out that first short introductory module. It's free to try out. See if you like my teaching style. If you do, maybe that can be the start of our radiology physics journey together. Otherwise, I'll see you all in the next video. Goodbye, everybody.